I would like you to stay with us. So we have next topic is Professor Ricardo Gomez. Is from Spain. He's your president-elect, I think, and will be after you. So it's topic about, let's see, disease-modifying drugs, a new approach to type 2 diabetes. So because we'll have questions, he'll not be with us, he'll be recorded. We're going to have all the question to Dr. Dror.
I'm really honored and pleased for the invitation to participate in the annual conference of the Emirates Society of Internal Medicine, which this year is held in collaboration with the European Federation of Internal Medicine. My name is Ricardo Gomez Huelgas, Professor of Internal Medicine in Malaga, Spain, and President-elect of the European Federation of Internal Medicine. And the topic of my talk is disease-modifying drugs, a new approach to type 2 diabetes. These are my disclosures, and this is the agenda for the next 20 minutes. What is the impact of cardiovascular disease in diabetes? Well, it's well established that diabetes is a major cardiovascular risk factor, and well known that cardiovascular disease is the leading cause of death among people with diabetes. 70% of the sex of mortality in diabetes people is due to cardiovascular disease. Despite that, mortality and the incidence of cardiovascular outcomes has declined substantially in the last decades among persons with diabetes. Fatal outcomes decline less among those with type 2 diabetes than among controls, as you can see in this Swedish study. On the other hand, although in the recent past, the focus has been on the atherosclerotic cardiovascular disease in patients with diabetes, we must remark that there is an epidemiological evidence that heart failure is much more common than other cardiovascular events, as myocardial infarction or stroke in patients with advanced type 2 diabetes. In fact, heart failure is the leading cause of hospitalizations in people with diabetes. This rate is exponentially growing in the last years, in contrast with hospital admissions for atherosclerotic cardiovascular disease that remain stable or decreasing, as is shown in this Spanish study. On the other hand, despite the fact that the incidence of end-stage renal disease is continuing to increase, we have not been able to reduce chronic kidney disease-related mortality. And, Also, we know that the risk of mortality increase as chronic kidney disease progresses, both in diabetic and non-diabetic patients, even with no very low glomerular filtrate rate. And cardiovascular disease is the leading cause of death in chronic kidney disease. What about the glycemic control and cardiovascular prevention in type 2 diabetes? So far, the classical approach to reduce cardiovascular mortality through reducing the levels of A1C with intensive glycemic control has shown disappointing results. Reducing A1C is important, of course, to decrease microvascular complications, but fails to reduce macrovascular complications and mortality. The observational extension of UKPDS suggests that intensive glycemic control in people with recent onset type 2 diabetes could prevent cardiovascular morbid mortality in the long run, legacy effect, but there is no evidence of cardiovascular benefit with strict glycemic control in the short term or in people with more advanced type 2 diabetes and high cardiovascular risk. In order to improve the burden of cardiovascular disease in type 2 diabetes, the multifactorial approach used in the STENO2 study was much more effective than other isolated glycemic control trials. However, we must remind that in the STENO2 study, the impact of glycemic control was far lower than the control of other risk factors like lipids or blood pressure. There are very few evidences about the effectiveness of classical antidiabetic drugs to reduce cardiovascular events. First, in the UKPDS, metformin reduced coronary events only in a small group of patients with overweight. Second, in the proactive study, pioglitazone was significantly superior to placebo for the key secondary endpoint, which was the composite of all-cause mortality, non-fatal myocardial infarct and stroke, but increased significantly the hospitalizations for heart failure. Paradoxically, the most important milestone in the contemporary diabetology came indirectly from a cardiologist. After this meta-analysis by Dr. Nissen, cardiologists from the Cleveland Clinic showed an increased risk of myocardial infarct in cardiovascular mortality with rosiglitazone. In 2008, FDA formulated guidance around the need to prove the cardiovascular safety of all new glucose-lowering agents for type 2 diabetes through specific cardiovascular outcome trials. The same decision was adopted 3 years later in Europe by EMA. Since then, a big number of trials with new antidiabetic drugs have been completed or are ongoing, with the results are being decisive to change our medical approach to type 2 diabetes. Let's summarize the main cardiovascular trials with new anti-diabetic drugs. The trials with DPP-4 inhibitors showed that the drug was safe from a cardiovascular point of view, with no differences of MACE with placebo. Also, the same non-inferiority of MACE was found in the Carolina trials comparing linagliptin with versus glimepiride. Respecting to heart failure, DPP-4 inhibitors are also safe, with an exception. Saxagliptin, the SEVER-TIME trial, was associated with a 27% higher risk of admission for heart failure. Respecting to renal function, DPP-4 inhibitor show also a neutral effect and only demonstrated some anti-proteinuric effects with no effect in glomerular filtration rate. History of antidiabetic drugs and cardiovascular disease started changing with the EMPA-REG outcome, because by first time an antidiabetic drug reduced major adverse cardiovascular events and cardiovascular mortality, as well as a dramatic reduction of hospitalizations for heart failure in comparison with placebo in a population with type 2 diabetes and cardiovascular disease. The absolute benefits of EMPA in patients with type 2 diabetes and cardiovascular disease in terms of number needed to treat is even better than other drugs of cardiovascular prevention like statins or ACE inhibitors. Since EMPA-REG outcome, other 5 randomized clinical trials with other 4 SGLT2 inhibitors have been published. Respecting to the reduction of MACE, the results are in general positive, but not always significantly, because probably by differences in the population included and the study design. For instance, in the CANVAS study, canagliflozin reduced MACE in a very similar way to empagliflozin in a population with 70% of patients with antecedents of cardiovascular disease. The same was observed in the SCORED trial with sotagliflozin in patients with diabetic chronic kidney disease. However, non-significant reduction of MACE versus placebo were reported with dapagliflozin declared in mostly 70% primary prevention population, with sotagliflozin in soloist in patients recently hospitalized for heart failure, and in VERTIS study with ertogliflozin in patients with secondary prevention. The most consistent benefit, without any doubt, described in all cardiovascular outcome trials SGLT2 inhibitors is an important reductions around 30% in the hospitalization for heart failure in the composite of cardiovascular death on admissions for heart failures. This benefit is present in different populations of patients with type 2 diabetes, with or without cardiovascular disease, with or without background of heart failure, with different grades of renal function. The prevention of hospitalizations for heart failure with this drug has even demonstrated also in non-diabetic patients with heart failure and reduced ejection fraction in the DAPA, IHA, and EMPERO-reduced trials, studies that included more than 50% of non-diabetic patients. Recently, the Imperial Preserved trial performed also in patients with and without diabetes and heart failure with preserved ejection fraction has shown that empagliflozin reduced significantly, 21%, the risk of cardiovascular death or hospitalization by heart failure. And these results can be considered an historical achievement because it's the first drug with positive results in a trial with preserved ejection fraction. However, the benefits came from mainly for a reduction in heart failure hospitalization without observational reduction in mortality in these patients. Well, another important and very consistent effect of cardiovascular is the renoprotective effects observed by SGLT2 inhibitors in cardiovascular autocardians, both empagliflozin, canagliflozin, etc. So this cardiovascular protective renoprotective effect is not only in reduction of albuminuria, also in the preservation of glomerular filtration rate and the prevention of renal failure. Well, it's true that this renal protection has been specifically demonstrated in a primary endpoint trial, credence trial, and also, and this is very remarkable, this renoprotective effect of SGLT2 inhibitor is independent of the presence of diabetes, as it was reported with dapagliflozin in the DAPA-CKD trial, with more than 30% of population was non-diabetic. An additional cardiovascular benefit of this drug is a significant reduction of atrial fibrillation in patients with type 2 diabetes and cardiovascular risk, as you can see in this meta-analysis with gliflozins. Summing up, as you can see in this snapshot, only prevention of heart failure could be considered a class effect of the SGLT2 inhibitor, also renal protection, but more studies are necessary to confirm if all cardiovascular benefits of SGLT2 are drug-specific or class effect. Well, these cardiorenal benefits by SGLT2 inhibitor are explained by unique pathophysiological mechanisms of the drugs that promoting diuresis of glucose and sodium and avoiding the sodium retention, hypervolemia, and the RAS and hormonal activation, characteristics of type 2 diabetes as well for their anti-inflammatory effects. The last group of anti-diabetic drugs we are going to deal with are GLP-1 receptor agonists, include a wide group of molecules from different origin, human analogs or animal-derived, and different long duration from twice daily to weekly. All of them requires cutaneous administration with the exception of oral semaglutide. We are going to summarize briefly the main results of cardiovascular outcome trials with GLP-1. Well, in general, we can say that human analogs, liraglutide, dulaglutide, semaglutide, have better results than animal-derived GLP-1 like lisizanatide or exizanatide. Regarding cardiovascular events, in general, GLP-1 showed a favorable tendency, not always significantly, and remarkably, these drugs seem to have an important reduction of stroke. Only liraglutide, once weekly exenatide and oral semaglutide reduced mortality, and they have a neutral effect in the heart failure outcome. Finally, GLP-1 have shown renal benefits in patients with type 2 diabetes and high cardiovascular risk, but in contrast with SGLT2 inhibitors, the renal benefit, this drug is mainly explained for its anti-proteinuria effect with a scarce effect over the deterioration of glomerular filtration rate. While the benefits of SGLT2 inhibitors can be explained mainly by their hemodynamic effects, the beneficial effects of GLP-1 receptor agonists on cardiorenal disease could be better explained for its anti-inflammatory, antioxidant, and vasculoprotector actions. All these evidences has been incorporated in the last guidelines of diabetes, cardiology, and nephrology. In short, these statements agree that nowadays it's crucial to manage patients with type 2 diabetes with a double approach. First, glycemic control through individualized A1C targets remain important, of course, to prevent microvascular complications and hyperglycemic crisis. In parallel, we also must evaluate the cardiorenal risk of our patients, and in this case, to use diabetes disease-modifying drugs independently of A1C target. In patients with cardiovascular disease, we should add or switch to SGLT1 inhibitor or GLP-1 receptor agonist. In patients with heart failure, it would be mandatory to add or switch to SGLT1 inhibitors, SGLT2 inhibitors, and in patients with diabetic renal disease to use glitazones or glyphosine, or GLP-1 receptor agonist in case of contraindication. Just to finish, the last consideration, despite the solid evidence of cardiorenal benefits of these new antidiabetic drugs, their clinical use still remains very low. It's being estimated that around 1/3 of our patients with type 2 diabetes would be eligible for SGLT2 inhibitors or GLP-1 receptor agonist therapies. However, there is a worldwide inertia in the use of these cardiorenal protective antidiabetic drugs, and most patients with type 2 diabetes and cardiovascular disease or renal disease are not prescribed SGLT2 inhibitors or GLP-1 receptor agonists. And as conclusions, we can say that the current approach to patients with type 2 diabetes demands not only to achieve an individualized A1C target, but also to evaluate the cardiorenal risk to add or switch to antidiabetic drugs with cardiovascular and renal benefits. Some SGLT2 inhibitors and GLP-1 receptor agonists have demonstrated reductions in MACE and mortality in patients with cardiovascular disease or high vascular risk. SGLT2 inhibitors reduce hospitalizations for heart failure and prevent progression of diabetic renal disease in patients with high cardiovascular risk. And new long-term trials with innovative science are needed to define better the role of these new antidiabetic drugs in the management of type 2 diabetes, for example, in people with recent onset diabetes, non-high cardiovascular risk, the elderly, the combination of dual therapy with study with active comparatives, study of long-term safety, etc. So thank you very much for your attention. I hope to see you, all of you, face-to-face in our next Congress we hold in Malaga, Spain, in March 2022. Thank you so much.
Thank you very much, Professor Ricardo. Unfortunately, he's not with us, so any question will be directed to Dr. Dror here. So in diabetes, here in Middle East is 1 in 3, 1 in 4 sometimes based on what is the latest literature in the Middle East we've published, I think, about 4 months ago. So common diabetes, and we getting among the acute coronary syndrome reaching about 70% of our patients are diabetic. And really it's been a great achievement having this medication on board now, SGLT2 and GLP-1, and really improving, not only being neutral, as only improving the outcomes. Any question to Dr. Dror regarding these medications, please, from the audience? I want you to ask. I could ask myself, but I want you to ask, please. I think the microphone is working there. Can you go there? I hope so.
With this class of drugs, we've seen cardiologists venturing into treatment of diabetes. Do you think that cardiologists are versed in treating diabetes?
Did you hear that, Dr. Dror? No, maybe you didn't
No,
hear it. Okay,
sorry.
so basically the question is, with this new medication, which got cardiovascular outcome, you think is the time for cardiologists to use this medication? Not just leave it?
Absolutely.
Are
Yes,
they
yes.
able?
I
Use it,
think
use it. I mean,
absolutely.
What do you think? He's asking kind of sarcastic question. Are you a cardiologist? I'm a cardiologist, that's why I'm asking. He's asking, are the cardiologists able to use this medication? Actually, we are using all the time, but I'd like to hear your point of view, Dr. Dror.
Yeah, so it's the same in Israel. So the cardiologists really use SGLT2 very often because it's wonderful and very important effect on cardiovascular, mainly on heart failure. We really see the effect in few days. So, and we really start to use it also in the departments, in internal medicine department, for those who have a very protracted and very severe heart failure when they are getting out from pulmonary edema and they are much more stabilized. We start them with SGLT2 and we will really see the effect of improving heart failure. Now, we know that we don't have good proof of treatment in HFpEF. And the only really prospective studies that show the effect of any treatment of HFpEF is the Emperor, so in empagliflozin. So I think there is no doubt today that for those with cardiovascular, using SGLT2 inhibitors is crucial. Regarding the GLP-1, we also use it a lot in those metabolic patients with cardiovascular disease, and I think it's obligatory to use it because the effect on the whole combination, the whole, if we want to really treat holistic the patient, the diabetic, the obese patient, you can treat with one drug and many side effects, or many complications of the disease. You can treat hypertension by GLP-1, you can treat diabetes by GLP-1, you can treat obesity by GLP-1, and you can treat hyperlipidemia by GLP-1. So if you give one treatment, you can really affect the whole of the complication of the metabolic patients. So I think it's really necessary, as mentioned in the guidelines, that patients with obesity and cardiovascular disease, or metabolic disease and cardiovascular disease, should be treated by one of these two drugs.
Dr. Hani with us? No. Okay. Okay, you can go. Thank you very much, Dr. Dror. So we're going to...
All right, so we've got... Dr. Hani is around. Okay.
I am.
Hani, you'd like to say something about cardiologists and new medication, diabetic medication, in the field of cardiology in general?
Yeah, so I think the innovation of the SGLT2 inhibitors and the GLP-1 receptor agonists has added like two very powerful tools to the armamentarium of prevention of cardiovascular disease in the metabolic patient, treatment of patients with heart failure. Even we know from the DAPA-HF study, the SGLT2 studies that we actually can reduce onset of atrial fibrillation and myocardial infarction. So these are universally accepted drugs in the treatment of established cardiovascular disease, but most importantly for prevention of the complication at early stages. So I think we all have to learn how to use them and also to phenotype and recognize this in the early metabolic stages.
Excellent. So I think we've had a great session on diabetes, on obesity, and now we'd like to shift gears slightly and bring in the thyroid. And